Hi guys, Ollie here. Welcome back to the channel. I am a final year medical student at the University of Warwick in the UK on the graduate entry programme. So this is going to be just a quick vlog style update, a bit of a talking head thing about my most recent block. I've been trying to do an update at the end of each of my academic blocks. So in the final kind of 2 years of the course at Warwick, what we call phase 3, you do a series of rotations. This is what kind of American medical students often talk about, where you're attached to a specialty for some period of time. For us, that was 6 weeks historically, owing to COVID and the time we lost when all the medical schools were closed. Basically, we're now only doing 5-week rotations. So since coming back, kind of post-COVID lockdown, I completed my 5-week acute medicine rotation, so A&E, emergency medicine, and now I've just finished my orthopedics or trauma and orthopedics musculoskeletal health rotation, and I find myself now in the first week of my general practice GP family medicine rotation, but this is about orthopedics. Now, I just use the term musculoskeletal health. That's the kind of formal name of the block because it covers trauma and orthopedics and rheumatology. So just to delve into what each of those are, trauma and orthopedics is the surgical specialty that's essentially dedicated to muscles, ligaments, tendons and bones. Basically, there is a fracture, we need to fix it. If you have a musculoskeletal problem, whether that's with a joint, a muscle, so on, any part of your skeleton or the things that attach to it, you will probably, if it gets bad enough, be seen by an orthopedic surgeon. It's, I think, the second largest surgical specialty in the UK. So you have general surgeons, which is that's the really kind of big specialty that covers most abdominal things. T&O is the second largest, but it's because you can imagine the huge need that our population has for T&O surgeons. Anytime someone breaks a bone or they need a joint replaced, or they experience a significant muscle tear, or they start to develop arthritis, you'll be seen by an orthopod. And then in terms of rheumatology, that basically describes autoimmune conditions. You might be thinking about things like psoriasis, lupus, rheumatoid arthritis. These are the things that people have heard of. Then you get into all your weird and wonderful, very rare polyangiitis, your vasculitis, your scleroderma, the seronegative spondyloarthritides, things like ankylosing spondylitis, reactive arthritis, all of these kind of rare conditions, but you do need to know about. So once again for this rotation, I was based at UHCW, University Hospital Coventry in Warwickshire, the big major trauma centre, teaching hospital. So that was awesome. I was privately kind of pleased. That's my favourite of the 3 hospitals to be based at. We were assigned a hip and knee surgeon as our consultant. You're usually provided a given consultant who is your point of contact. So we had a hip and knee surgeon who actually operates much of the time at Rugby Hospital, which is obviously not in Coventry, is more towards rugby, of rugby school and the sport of rugby fame. So that meant that some of the time we were hopping between these 2 different hospitals, but that really wasn't too bad. And we were a bit worried, just as in acute medicine, we were worried that we weren't going to be able to see that many patients. And certainly I think we saw less patients than we usually would on a rotation. This is because with orthopedics, they had reduced the number of elective clinics that they were doing. So not emergency cases. All emergency cases such as fractures, spinal injuries, things like that, were all being dealt with appropriately and quickly. Elective problems, things like joint replacements, there is a huge national backlog because elective clinics are not going ahead at the speed that we would like them to be because of COVID and the restrictions, and equally those surgeries are not taking place at the capacity we would like. But we still did manage to go to some clinics. We saw fracture clinic. That was probably where we were most commonly. We were on the wards a little bit, so we could actually examine patients with bony pathology and relevant clinical examination signs, and that's really important and really valuable. We got into theatre twice. We had 1 session of upper limb. Essentially, we saw a few things, and 1 session of lower limb. So we saw a hip replacement, a knee replacement, rotator cuff surgery, elbow joint aspiration. We saw a good mix of things, the kind of classic orthopedic presentations you would like to see. And we were actually able to spend time doing kind of one-off clinics with specialist orthopedic surgeons. So some of them might have been pediatric orthopedic surgeons, some of them were more trauma focused, Some of them were more joint replacement, because particularly by consultant level, they very much tend to specialise, whether that's upper limb, lower limb, they might just do hips, they might do hands, they might just do muscular repairs. So definitely if you have an orthopaedic placement in your medical school, or you're maybe doing some work experience, try and speak to all the different surgeons, because they will probably have their own very niche area of interest. And one of my favourite clinics from the block and some of my favourite clinics from the block were the Pediatric Clinics. Again, as you know, I'm kind of developing this interest in paediatric surgery and paediatric medicine. So in that instance, for example, we learned a lot about congenital problems, such as developmental hip dysplasia, things like Perthes disease, Sufi's, and all these other problems that you have to be concerned about specifically with children and how you manage them appropriately. We also did some clinical skills. We learned to do plaster casts, and we had to plaster cast each other. I don't know if you go and follow me on Instagram at Ollie Burton Med. When I post pictures from my placement, you'll see them come up. But I don't know how easily you can see this. My clinical partner Jodie did a really good job of putting this, what we call a back slab, because this you can see is quite compressible here, but on the back, that's very solid. So if I had a fracture either in my wrist or I guess in my distal forearm, that back slab would hold everything in place, would stop the bones moving around. And in a fracture, when bones move, you get pain. So the way to stop pain is by immobilizing the bones. You do that with a plaster cast. Something else you might find quite interesting is my housemate Emily, her mum, thank you Mrs. Watson, made us some masks in the house. So I've got this very exciting polka dot, hopefully that's not muffling me too much, but these spotty reusable face masks, which I took from Pudsey Bear himself. He fought bravely, but ultimately it was I who got the spotty handkerchief, which I now use for a mask. I realise I sounded incredibly northern when I said that, my inner Yorkshireman leaking out. It hasn't been all positives for the block, just for the sake of transparency and the sake of learning and medical education. You may find it interesting to know, in my graded end of block, what we call an OSLA, a long case, where you see a patient yourself, take a history, examine them, and present your findings, which we had to do with one of the consultants, because we can't actually arrange patients to do OSLAs on. It's very difficult owing to the current COVID guidelines. I am a little bit worried about our clinical skills progression, just because we can't actually examine that many people, and that's a really important part of being a finalist medical student. I had to do a hip history and a hip exam, and only one of the two questions that I got. So essentially I took my history, did my exam, which I essentially failed the exam, because we ran into a situation where, partially because I was not very well practiced doing hip exams, I certainly could have been prepared better than I was, but I've not done one in a very long time. And then secondly, we just ran into this variation that is a problem in medical school. It's not a real problem, but it happens, where there is often huge variation in what different consultants will like you to know and ways that they like you to do particular things. And one thing that you'll realise rapidly about doctors, but particularly surgeons, is that basically everyone thinks that their way of doing something is the correct and most perfect way. And what I mean by that is, I'm not saying that I know any better than the consultants, because obviously I don't. Like, I've been taught different things by different consultants, but if you got two orthopaedic surgeons in a room and asked each of them to do, say, a hip or a knee exam, they'd each do it in a slightly different way, and each would be convinced that the other was wrong. And so this was just a situation where I'd spent the afternoon before seeing one consultant do hip exams for 3 hours and thinking, you know, this looks really slick, I'll do it this way. And then went to have my examined one with a different consultant who was like, this is one of the worst hip exams I've ever seen in my life, who taught you to do this? And it's just a bit of a bashing your head against a brick wall situation, but that's the way it goes. So even if you start to feel more confident like I do, you can still be knocked on your ass very much by an unimpressed consultant, let's put it that way. Then the only other real thing I want to touch on now is that we are very much preparing for the final stages of medical school now. I have my job applications to do September, October, November, so over the next few months. I'm preparing to apply for the Academic Foundation Programme. I don't know how good a candidate I am. We'll just have to see. I've decided that it's worth the punt, so I'm trying to get a job in medical education alongside my clinical rotations. I think I would really like that. And then I need to prepare for the SJT, the situational judgment test as well. And this is something I've talked about loads before, but essentially it constitutes 50% of your score that ultimately decides what your F1 job is. Your SJT is a huge decider. It's basically the decider. The thing is, I'm an okay candidate maybe for both programs. I've got a first class degree. I'll have at least one publication by the time all these points come in. I should do reasonably well statistically on the SJT, so we'll just have to see. Warwick tends to do pretty well, and the coaching is good that they give you. I'm debating, investing in a course, in a few books. It's difficult to know. You get a lot of conflicting guidance about the SJT. But yeah, that's basically where I'm at, guys. But basically, my content output is slowing down a little bit, and that's why I'm just trying to maintain my other things, get my final bits of research done, kind of get everything together, so I can't spend as much time on YouTube, Instagram, and the rest of it. But my interviews book is very, very close to coming out, so close. And I really can't wait to share that with you all. I've got a few videos on personal statements coming out very soon. And then as soon as the book's out, I've got a load more interview station videos to release, and hopefully that will support you guys kind of through the interview process. Something that I'm not looking forward to this year will be that I will have to be drastically reducing the number of mock interviews that I'm able to do this year, purely because I've got my finals to think about. And I'm sorry, that's really selfish. And honestly, doing that with you guys every year, I'm now at over 200 mock interviews that I've done through MedSchool, which I'm very happy with. But it's been one of my favourite things since coming to medical school. And this year, I'm still going to be able to do some, but I'm not going to be able to do as many. So I'm going to think of other ways that I can support you guys in helping you get through that interview process. All right, guys, that's where we'll cut it. That's all from me for now. Thanks very much for watching. Please be sure to hit that like button for me, leave a comment, subscribe, and don't forget to go and check out ollieburton.com, my newly rebranded website for all of my videos, articles, tips, and tricks in one handy location. Take care, and I'll see you next time.